A patient with bradykinesia, rigidity, mask-like face and slow gait. What would be the treatment option for this patient? So here we share with you the notes and our treatment option from our notes. So this is a case of Parkinson's disease and how we go along with the treatment in Parkinson's disease. So it's either a dopamine decrease in the dopamine that is happening, giving rise to the rigidity part and the bradykinesia part of the movements, and the second is as a result of that there is a acetylcholine increase. So this generally gives rise to the tremors part, or what we call as the important anticholinergic drugs that we have to give for these patients if these symptoms are dominating, and if bradykinesia movements are dominating, we have to go with increasing the dopamine levels. So what do we do and how do we decide for the treatment of these patients? We look for the functional status of the patient. If it is good, the patient is young, less than 60 years of age, then we go with the dopamine agonist, that is the bromocriptine, ropinirole, pamipixole and the pergolide. Then greater than 60 years, the age is good, there is no functional status is there in the patient, we go with the catechol-O methyltransferase inhibitors. Then in this patient what we have is the patient is having symptoms, and in the options we don't have any of the option of the dopamine drug. But what we can do is we can give these patients drugs that increase the amount of dopamine, that is catechol-O MAO-B inhibitor, that is selegiline will be the drug that is to be given in these patients. So the answer over here will be selegiline. Donepezil, promethazine, clozapine have no role in these patients. Obviously in drugs that we have excess of acetylcholine symptoms, like in the form of tremors rather than bradykinesia. In this question it is clearly mentioned that the patient is having bradykinesia. Patient is having bradykinesia, rigidity, the face is a mask-like face. There is no mention of tremors in this patient. So in these patients generally we don't go with the anticholinergic group of central anticholinergic group of drugs, that is the trihexyphenidyl or the benzhexol, which is also a drug of choice for the drug-induced Parkinson's disease. Now the next question, again a very common question that gets asked in the NEET-PG exam, that is which of the following does not occur in men 2B syndrome. So here is the table from Harrison. Guys, there is nothing special about this MCQ. You just need to know what are the things that are there and what are the things that are not there. So in men 2B syndrome, so here you can see this is the men 2B syndrome. This is the men 2B syndrome, and in this men 2B syndrome what do we have is we have mucosal neuromas, you have marfanoid features, and you have the megacolon. So you can see that all the three were the options. You have mucosal neuromas, you had marfanoid features, and you had the megacolon. So what does not occur is the parathyroid adenomas. Parathyroid adenomas, they come with men 1. Obviously we have this men 4 as well. Men 2B is sometimes also called as the men 3 syndrome. Men 3 syndrome. Now coming to the next question, patient comes with fever, dyspnea, there is fever, there is dyspnea, there is cough, night sweats since 2 to 3 months, and the patient on examination shows muscle weakness on both the sides of the face. So there is a facial palsy in this patient. Then the patient has a red eye on both sides. Features of facial palsy are there. Then important hint was bilateral hilar lymphadenopathy. Bilateral hilar lymphadenopathy was a important hint that was given in the question. Obviously the things that we need to differentiate was, obviously lymphoma will not be like this, so this is ruled out. Hypersensitivity pneumonitis is ruled out. What remains is tuberculosis and sarcoidosis. So the option that is there, fever, dyspnea, cough, The patient has muscle weakness. This is all because of the sarcoid features of the central nervous system. There's a typical feature, bilateral hilar lymphadenopathy is there to the patient. This is sarcoidosis. Now the next question, the patient presents with anorexia, jaundice, right upper quadrant abdominal pain. Investigation shows positive for HBsAg, anti-HBsAg negative. Then the most important hint in the question is IgM anti-HBC positive. IgM anti-HBC positive. What is the diagnosis of this patient? So it's very clear. So here you can see our notes, guys. So in the notes, it's very important to understand these type of questions have been regularly being framed in the NEET exams, which is the first antibody with a second antibody, which antibody comes in the window period. So the first to appear as far as the antibody or the marker to be there is HBsAg. Then the first antibody to appear is the anti-HBsAg, and that too it is the IgM variant. It is the IgM variant. So in between appearance of HBsAg and appearance of anti-HBsAg, the period that is there is called as the window period. So they ask you, what is the investigation of choice in the window period? So it is IgM anti-HBc, that is the antibody to the core antigen. It's the core antigen antibody, guys. Core antigen antibody. Now serology, how do you differentiate the most reliable marker for the acute infection? Most reliable marker is the core antigen. Remember this nicely. Most reliable marker is the core antigen. Don't pay attention in the questions when you have. Don't put too much attention on what is happening with this. These are just distractors, you can say, at a point. And important to note is what is happening with this core, whether the score is a IgM antibody or whether the score is a IgG antibody. So here in the question it was a IgM antibody. So this is a acute hepatitis B infection. Obviously there is no question about the hepatitis C virus, as the anti-HCV hepatitis C virus is negative. We have to always keep into mind, guys, that whenever hepatitis C virus is being mentioned, all the letters are in capital H, C and V. This is hepatitis C virus, right? Whenever we are mentioning about the core antigen, so it is H capital, B capital, small c in the foot of the B, HC hepatitis B virus core antigen. That's how it is written. Many times when we are reading the questions very fast, we may students may get confused. Then the best marker for the infectivity, it is the DNA polymerase. The gold standard for the replication, it is again the hepatitis B virus DNA PCR. Then this table that is there in the Harrison, it comes quite frequently in the exam, so this table needs to be remembered very nicely. And out of this, the most important thing that needs to be remembered for solving these type of questions is what is happening to the core antigen. The antibody developed is whether it's IgM or whether it's a IgG. That will decide whether the patient is acute infective patient or whether it is a chronic infective patient. So now moving to the next question. Again, the next question is simple in that sense that where you have the ABG values are given, the patient definitely has a low pH. So this is obviously acidosis. So the alkalosis options are obviously ruled out. Now you have the high PCO2 levels and the bicarbonate levels that are given. Not sure about what the exact levels are, but it's an acidosis, and definitely the carbon dioxide levels were very high that were given. So when carbon dioxide levels are very high, pH is low, CO2 is high, and bicarbonate is increased. Bicarbonate is increased, is trying to compensate. So this is a clear-cut case of a respiratory acidosis. Nothing difficult about this question. Now comes the question of a patient with ALL and lymphoblast in the smear. So this is a lymphoblastic crisis where the patient is developing pain in the abdomen, decreased urine output, so there is a liver failure developing. Workup shows increased potassium, increased uric acid levels. What is the next line of management? So this is a question on the tumor lysis syndrome. So here is our notes. So screenshot from our notes, guys. So tumor lysis syndrome is typically you have increased potassium, you have acidosis, you have increased urea. Importantly, what you don't have is a increased calcium. You have a decreased calcium level because calcium will be binding with the phosphate. So all of them are increased except the calcium. So here we had the increase in the potassium levels and increase in the uric acid levels, and the patient was having a renal failure or a decreased renal output. So they asked you what is the next best step in the management. Obviously the next and the best step in management will be hydration. Other options were probenecid, urgent chemotherapy, and USG abdomen is to be done to the patient. So you go for the hydration. The drug of choice for the prevention is allopurinol, and for the drug of choice for acute management is rasburicase. So that's how you manage the patients of tumor lysis syndrome, very commonly seen post chemotherapy patients of the ALL. Next is a female patient. Young female patient has come up with the, so here are the our notes, screenshot from our notes. So patient has come with, important hint is arthralgia and not arthritis. Along with it you have the oral ulcers, you have the skin rash. So this is a very clear-cut case. The patient is a clear-cut case of a SLE. The patient is a case of a lupus nephritis. So lupus nephritis, you have glomerular RBC cast, so you have a dysmorphic RBCs. Then the typical appearance that we see is a wire loop appearance, and that is a lupus nephritis. There are 6 stages. The most common stage to be seen is stage 4 in the patient. This is not a case of post-streptococcal or a IgA nephropathy or a Goodpasture syndrome. Whenever the questions are framed where you have to pick in from the option between a post-streptococcal and a IgA nephropathy, it is generally a differentiating point that is given is hematuria occurring after how many days, whether it is in the first 7 days or 10 days, or whether it is in the at the 21 days after the streptococcal infection. So it's either a post-streptococcal or a IgA nephropathy. Then the next question is a female patient presenting with fever, presenting with polyarthritis, history of sore throat 45 days ago, right? Throat swab is positive for streptococcus, ESR is raised, echocardiography shows no valvular problem or features of carditis. So there is no carditis, no valve involvement, no past history of rheumatic heart disease. Prophylaxis to be given is benzathine, penicillin, 6 lakh international units every 3 weeks, and the option is for how much time duration. So here is the chart that we have. Some of the students say that the option over here had, instead of 21 years, it had 18 years. So what we see very clearly is that the recommended prophylaxis that is given to the patients are divided into 3 major groups, where you give the prophylaxis to the patient without any sort of carditis, without rheumatic fever, with no carditis. You give the prophylaxis for 5 years after the last attack or 21 years of age, whichever is longer. Then if the patient is having carditis and no valve involvement, then you give it. Carditis is to be given for 10 years or 21 years, whichever is the later. Then persistent valvular disease is also there, that can be evidently or clearly seen in patients via clinically or via the echocardiography. Valve involvement, you go for 10 years after the attack or 40 years of age. Sometimes a lifelong prophylaxis. So prophylaxis ranges into 3 options: no carditis, no valve involvement, 5 years. Carditis, no valve involvement, you go with the prophylaxis for 10 years or 21 years of age, whichever is longer, right? And finally you have valve involvement. Valve involvement will have maximum prophylaxis. There either 10 years of prophylaxis or 40 years of age, whichever is later, or some also give it for a lifelong prophylaxis. So in the question, always when they are asking you about the duration of prophylaxis, this will be very clearly mentioned. So you need to pay attention to 3 important things: whether there is carditis, whether there is valve involvement, or whether there is both. So it's very important to understand the nature of the question depending upon the options and depending upon what is being asked in the question. Now coming to again a question, it's a simple question. Chronic liver disease, the patient develops ascites and diffuse pain is there in the abdomen, and the patient on tap shows 600 polymorphonuclear cells. So it's a clear-cut case of a subacute bacterial peritonitis. Some of the students have mentioned that the option was a spontaneous bacterial peritonitis. Whatever may be the cause, the cells, polymorphonuclear cells, are generally greater than 250 cells, and the most common organism that you find in these is the E. coli. Now the next question, again the patient presented with features of meningitis. CSF tap showed increased protein. So proteins are increased, decrease glucose. So increase proteins, decrease glucose. We already know what the answer is. Histology, sample from where the sample was given, the image was given. So the image clearly showed the cobweb. Acid fast bacilli, which is a different kind of an appearance as far as the color of the slide goes. So even if the color was like pink, so the pink color of the slide is generally because of the stain that we do for CSF. So that was definitely a CSF stain that was given. So CSF stain was a May-Grunwald stain. CSF stain was the May-Grunwald stain. Acid, it was not a acid fast stain most probably. So whatever may be the stain case, the important hint that was there was the image of a cobweb. So the answer is clear-cut tuberculous meningitis. Then treatment of acromegaly, growth hormone receptor antagonist was asked. Absolutely outright simple question, the pegvisomant. Then you have a young female patient coming with amenorrhea, galactorrhea. So the 2 symptoms are important: amenorrhea, galactorrhea. Then MRI of the brain showed a pituitary macroadenoma. Pituitary macroadenoma. So remember guys that this macroadenoma part that was given, this was just a distractor. Many students, they try to read the questions too much and they end up answering the questions wrong. So this is a clear case of prolactinoma. Amenorrhea is there, galactorrhea is there. The drug of choice that we give is a bromocriptine, very simple. But prolactinomas, these are the most common pituitary hypersecretion syndromes. Whether it's male or female, most common pituitary hypersecretion syndromes. And these prolactinomas can be micro or macro. Micro is generally less than 1 centimeter, we know this, and a macro is greater than 1 centimeter. Whether it's a micro or whether it's a macro, obviously 90% of these prolactinomas are the micro variant. Then the important level that may be given in these patients is the prolactin levels. So in this question it was not given, but you may get in the questions prolactin level that is generally greater than 200 microgram per liter. 200 microgram per liter. How do you manage this patient? We need to know the simple loop of management. So for the loop of management, we know that pituitary has these cells that is having D2 receptors, that is dopamine receptors that are there, and they have a positive effect on the release of prolactin. Then we have a hypothalamic component, and hypothalamus releases dopamine, and this dopamine acts as a negative feedback or inhibitor to the release or decreasing the prolactin secretion. So the treatment that we use is, the drug of choice for this is the dopamine agonist. And here the dopamine agonist is the bromocriptine. Bromocriptine is the drug of choice. Now coming to the next question, again a simple question. It's a case of diabetic ketoacidosis where the patient, known case of diabetes, presenting vomiting, abdominal pain and confusion. Patient has tachypnea is there, patient has a low blood pressure, and patient has a very high blood sugar levels. Patient also have urinary ketones. What is the treatment to be given? What is the treatment to be initiated? So obviously the correct answer that is there, it was IV fluids were given, regular insulin was given, IV fluids with regular insulin or a long acting insulin. So the best option out for us is IV fluids with regular insulin. So we initiate the treatment simultaneously. So there is a small snapshot from our notes how we manage the patients of diabetic ketoacidosis. So the first thing that needs to be done for diabetic ketoacidosis is you confirm the diagnosis of the diabetic ketoacidosis. So you assess the electrolyte levels, you assess the KFT, and you look for the important variations. The drug of choice, if they ask you and give you a single option, then it is IV fluids. If they ask you what is the IV fluid of choice, the IV fluid of choice is the normal saline. It is the normal saline. So you give 0.9% saline over a period of 2 to 3 hours. 2 to 3 liters of saline is to be given, which is followed by a 0.45% of saline, that is 250 to 500 ml. Next, you assess, along with this, you assess the blood sugar levels, and when you are assessing the blood sugar levels, you initiate the insulin. But the most important thing that is to be taken care of before giving insulin is to look for the potassium levels. We have to see what is happening with the potassium. If the potassium is low, insulin will be contraindicated. We have to correct potassium first and go for the insulin part, right? Then if the potassium is right, we go with the insulin. Along with the insulin, we also give dextrose, and the insulin of choice that we use is a regular insulin. Regular insulin is the drug of choice. So here the option that was there, that is IV fluids along with regular insulin, is the treatment that is to be given to these patients. Next question, a patient who is on chronic antidepressants, right, develops acute onset of discomfort and confusion. There is increased temperature, there is low blood pressure. ECG shows a wide QRS complex and a right axis deviation. So this is the anticholinergic side effects of the tricyclic antidepressant. The answer is pretty simple. You go with the sodium bicarbonate infusion for this patient. Now coming to the next, this from the hematology side, a old patient presents with post-meal fullness and dragging pain in the abdomen, has a massive splenomegaly, blood picture is showing leukocytosis, importantly myelocytes and metamyelocytes. These two words are sufficient enough for us to go with the diagnosis of the CML. So this is a patient of CML. Eosinophils are also increased, basophils are also increased. Some students say there were the percentages of eosinophil and basophils were given like 10% of eosinophils and maybe 4 or 5% of basophils were given. The translocation that is to be seen. It's a Philadelphia translocation between 9 and 22. So here are a few things about that Philadelphia translocation. We need to know this chromosome number 9 has the ABL region and chromosome number 22 has the BCR region. So the 9 part from the 9 breaks and goes and attaches to the 22. So it is a shortened chromosome 22 that is called as the Philadelphia. It is the shortened chromosome 22 that is called as the Philadelphia, and it activates. There is a gain of function mutation. Both the two important regions have come together, they get activated, and because of that activation the JAK-STAT pathway gets activated. The best for diagnosing these patients is a fish, best for the diagnosis. Then one more important thing, that there is one more chromosomal translocation that is called as a masked Philadelphia. What is a masked Philadelphia? Whenever there is a translocation occurring between chromosome number 9 and any other chromosome apart from 22. So 9 with 21 or 9 with anybody else other than chromosome 22 is called as a masked Philadelphia. Then the next question, again a pretty simple question that we have. A female is brought to the emergency where the female has taken 20 tablets of paracetamol. What is the antagonist that you give? So N-acetylcysteine is the correct answer over here. Then there was one more question, we have not included it here. Maybe these questions were typically from the pharmac side, that the patient has taken up opioids and they have asked the antidote for the opioid. So naloxone or naltrexone. So the answer is pretty simple. So the answer is pretty simple. You go for the naloxone. Finally, coming to the last question. Again, it came up with a histological slides. There is a 4-year-old boy, history of frequent falls, and whenever he tries to run, has difficulty in getting up and from the squatting position. This is typical. What has been described is a Gover's sign. So the patient tries to or stands up on itself. The muscle biopsy image is given. Which of the following is true, it is asked. So the answer here is the death usually occurs in the 3rd decade. So the Duchenne muscular dystrophy, there is pseudo hypertrophy of the hypertrophic muscular dystrophy is there. It becomes apparent generally at around 3 to 5 years of age, where the patient has boys have a repeated history of fall that is there. The sign that was described, typically difficulty in getting up from squatting position, is what we call as the Gover's sign. We need to differentiate, guys, between the Duchenne and the Becker's muscular dystrophy. There is a table that I have from the Harrison. You can see that the inheritance is X-linked recessive inheritance of both the disorders. The problem is with the protein dystrophin in both of them. What we see is the onset age is very early in patients of Duchenne, and generally in the early childhood or adulthood. The onset is very late in Becker's. Becker's is a milder variant. Duchenne is a severe variant of the disease. The progressive weakness of the girdle muscle is there. Patient is generally unable to walk by the age of 12. There is progressive kyphosis, and respiratory failure typically develops in the 2nd or 3rd decade. So this was the important option that was given in the question. So 2nd and 3rd decade respiratory failure developing in the patient. Both of them have cardiomyopathies. So cardiac involvement, muscle involvement is there in Duchenne as well as Becker, but Duchenne comes with mental impairment as well. So these are some of the important distractors or some of the important hints that may be given in the questions that are asked on muscular dystrophy. So these were some of the questions, guys, that we could get from the recall of the students. Hope that they serve the purpose. Our purpose is to understand the pattern of the questions. There might be some discrepancies about certain questions, but that's all right. It's a recall based questions and not the exact questions. So we hope that the result is you come up with flying colors and with the best of the marks that you have, so that you get into your dream branches. But definitely the competition will be very tough because the paper was very easy. So the scoring rate will be very high. 1 or 2 MCQs or 2 to 4 MCQs here and there will make a huge difference as far as this exam is concerned. So thank you very much for watching the MedCompanion videos. We'll be coming up with more medicine videos for the NEET-PG, INI exams, the FMG exams, the DNB exams, the USMLE exams, the PLAB and everything we have. So hope to see you soon next time. Thank you very much.